So sumptuous food and long queues are a disaster for the next upcoming session. So I think we have got both the combinations. The food is yummy and the queue is long. But nevertheless, what's missing in quantity will be made up with quality work. Okay. So we have got our chairperson, conveners of the session. My pleasure to introduce Dr. Gautam Zaveri and Dr. Abhilash Dhruv, and also the chairpersons for the session, Dr. Nikhil Joshi and Dr. Kapil Mohan. Welcome all. And without further ado, I'll request the chairperson to take over the proceedings, inviting the first speaker to the podium.
All right. Good afternoon, everybody. Welcome to WIROC post-lunch session. Let's start with our session today. May I call upon first speaker of the day, Dr. Satyen Mehta. His talk is Quadriparesis after cervical decompression.
Good afternoon, everyone. Thank you for giving me this opportunity. So this is an interactive case discussion on post-operative deficit. This 70-year-old male came with bilateral upper limb and lower limb weakness. He had spasticity, quadriparesis. He was still walking, but he had grade 4+ power. No bladder bowel deficits. He was a hypertensive and some history of ischemic heart disease, but no procedure was done. And this is what his MRI shows. So I'd like to involve the faculty at this stage itself. Dr. Zaveri, I will not involve you because you know about this case already. Dr. Badani, sir, at this stage, what are you thinking of? I have limited pictures. So this patient has OPLL seen on the X-ray as well. There is no frank instability, but there is a definite OPLL element here.
So he needs, he's a quadriparetic, right?
Yes.
So he'll need decompression along with stabilization at these two levels.
So decompression at 4-5 and 5-6?
Posterior.
And stabilization at those two levels?
Yes, yes.
Anything about the prognosis that you would like to tell this patient in this? Is it different from any other patient as to how you counsel them?
Yeah, there is a greater chance of post-operative neurological deficit due to the type of disorder that he's suffering from. And also again, recovery you cannot guarantee like in any other conditions, cord compressions.
Dr. Nikhil, any other comments? Is fusion the way to go here?
Generally, in fusion, I usually keep it for the young or middle-aged patients, considering that he's already have a ischemic heart disease history and medically not very fit. I would consider decompression as a first part, but as a rule, in every cervical myelopathy patient I'm doing posteriorly, I usually get a CT scan and a flexion extension X-rays done. And if there is any evidence of instability on those X-rays, I would fix it. Otherwise, I tend to do only decompression, which is a quick in, quick out job. And at the same time, that will minimize the amount of anesthesia as well. Regards to counseling part, I usually tell my patients that this is a preventive surgery and this is for prevention of further deficit. Whatever deficit you already have may or may not improve. At the same time, there is a risk that because of the sudden decompression of the cord, which has been compressed for a long time, it is possible that it may increase, and that may be because of the cord edema.
So I'll go ahead to what was done. We did a decompression and a stabilization of this patient. Since he had a OPLL from high level, I've done from a C3 to C6 laminectomy, and lateral mass screws were put in. As a rule, at every OPLL case I do a fusion to get a better lordosis and to prevent post-operative kyphosis as well. This patient, the surgery went quite uneventfully, and he woke up with a normal neurology, which was equal to what he was pre-operative. But as the day progressed, I started getting calls from the RMO that he started complaining of some weakness in the legs, which I thought maybe it is not such a big deal. Maybe he's not checking it very well. Maybe he's a little drowsy. And by evening, that call became that he's not moving his legs at all. And so progressively, he started getting weakness, and now from being normal, he has now progressed to becoming grade 0 power by evening time. So this is around 8 o'clock or so that this has happened. What would you do next, Abhilash? Anything that you would? What is going on in your head?
Yeah,
right
so
now?
first things first, a slowly deteriorating deficit after the patient wakes up with a normal preoperative neurological status is definitely a red flag. You are not going to just wait and do nothing. First things first, you will want to investigate this. I'll order an MRI. At the same time, the first thing which is going to strike me is because there's a history of a clopidogrel, there's a very high chance that this could be a post-operative hematoma, which is compressing the cord secondarily. So definitely document that and go ahead and open it if it shows a hematoma.
Dr. Badani, patient has already has a drain put in place, and the drain is also functioning. So do you still think that this could be a post-operative hematoma?
Yeah, even in presence of drain, you can get compressive hematomas because the drain may not be draining everything. It might be blocked, might be draining part of it. There could be clot formation.
Anything else that is in your mind? Any other differential diagnosis? What else could cause it?
It is slowly progressive, so any ischemic things are likely, but possible, but not likely because.
Dr. Zaveri, anything to add here, sir? Anything else other than a hematoma that could explain this?
Well, you could get not only hematoma, it could be a cord edema. You can get a ascending cord edema post-operatively, which could have happened because of manipulation of the spinal cord during the surgery, and that can also cause this. I think the first 2-3 steps which you should take is that you should immediately check that your blood pressure is maintained, and you should try to keep the mean arterial pressure about 90-100 in this patient
This
in order to keep
intraoperative.
this thing. No, post-op also, once you have realized that there is a neurologic deficit, the second thing that you must do is maintain is oxygenation also for the cord. Third is that if you are a believer, then you should be giving solumedrol to reduce the cord edema. Fourth is check the drain, whether it is working adequately or not. If not, obviously. And the fifth thing is, as Abhilash said, that you must do an MRI scan immediately in order to see what is the cause. If the patient has woken up from the surgery, post the surgery with neurology, then you are thinking more in terms of cord manipulation or cord injury because of this thing. Here, it is a weakness which was not there and it is now developing. Cord edema is certainly one, but one of the most common causes, as you all mentioned, is a hematoma, and that is something which we should be looking into. Displaced hardware, if it was there, if you have put a fixation, would have presented immediately post-op. It is again not something which you would present after some time. So yes, your first diagnosis here would be a hematoma, and you need to actually look at it on an MRI scan.
So I'll go to the MRI. This is what the MRI showed. This is what his immediate post-op MRI shows. The drain which was present inside is still functioning, but still this is what is present. Your thoughts?
Did you
Nikhil?
use gel foam in this?
Yeah. So basically, this is what I don't use anymore. But at that time, we used to use a very thin layer of gel foam on the dura, and this is what is a gel foam which has basically swollen up and started and given the cord compression. So,
Yes. So there are plenty of reports in literature which show that gel foam, when you use it sometimes, not all the time, but sometimes it admixes with the clot and swells up and can cause cord compression like this. I have had one patient in the dorsal spine who has had, then I re-explored and removed everything, and she recovered neurologically. So anyway, now here you can see there is very significant compression. The question is there any role for conservatism or not in this patient? So let's ask Dr. Badani. How should you proceed now that you have seen this MRI scan?
No, he would require evacuation of the hematoma.
How early he was on clopidogrel? So with this your scenario, already the patient has landed up with a hematoma. Are you going to go immediately? Will you wait for some time, for a day or so, to see whether the just give steroids and see whether the patient is improving? What would be your approach?
There is significant amount of compression, and at the most you could use tranexamic acid and vitamin K and all that. Prime up with those drugs and go as early as possible, because the longer it remains compressed, it's going to be difficult in recovering.
Abhilash, what would you do?
So my threshold for exploring this is very low. I would definitely, once I've documented that there is severe compression of the cord, I would go in and definitely evacuate the hematoma. This time maybe put 2 wide bore drains to hopefully prevent this from happening again. Of course, along with whatever measures you already mentioned.
Right. So, Nikhil, you go in there, you'll see that there is this gel foam mass and all. You'll obviously remove it in this thing. But before you go in there, what are you going to tell the patient's relative? Now, this patient has gone from grade 4 to grade 0, and you are going in to evacuate the hematoma. How do you counsel the relative in terms of improvement in neurology, in terms of what you are going to do, why this has happened? What are you going to tell the doctor?
So first thing is to clearly mention to them the clinical status of the patient, and they obviously know that he's not moving, and tell them that we have done the diagnosis on MRI that there is a compression which needs to be removed. At the same time, in terms of improvement, it will be a gradual. It will be assisted with maybe 3 or 4 days of steroid therapy afterwards. But really, we cannot guarantee, and it has to be assessed on day-to-day basis after surgery. But considering that we have got a diagnosis, there's a compressive element, there's a fairly good chance that he will improve, and it has to be a sympathetic approach to the patient relatives.
Satyen?
So I'd like to add here that for this patient, I had counseled them. I've been very, very open and direct about what was going on. And I explained to them that we need to do it immediately. We need to get all the blood clot out and whatever is compressing out, and then wait and watch and see how much he improves. And after the, should I just go ahead? So even after that, I have done a decompression. I've gone in and I have removed everything off. And he started getting improvement immediately. As soon as he woke up, he started getting improvement. By morning. He was grade 2 plus power. And then physiotherapy was gone on at home as well. And he continued to improve, but he never regained the full power which he came with pre-operatively. He was grade 3 plus or so, but he was walking with the help of a walker, but never regained that. For this patient, if I may add.
Satyen, you know that if you see the C7 lamina, the upper end of the C7 lamina seems to slightly be digging into the spinal cord. Is this something you think may be a deterrent to complete recovery?
Yeah, it's not that bad on the axial views. Actually, there is a little bit of an artifact here, so because of the screw and the rod, so that's why it appears that way. But it was quite clear, and on table it was very open, so it was not an issue. For this patient, you got to keep your complications very close to you. So I was very, very open. I used to go and see. I have even gone to their house and seen him, on a monthly basis on my Sunday mornings, and kept on explaining, etc. They were reasonably good. In spite of that, there was, they still consulted some other spine surgeons, and they were told, "Ke, after that, ho gaya hoga, handling may have happened, and it can happen." And then, they came back with, they said, "Kuch hua kya? Something happened during surgery, etc." So those doubts still kind of remained in their head. But, you can do what you can do. So they, of course, did not cause any problems. They still remain good patients, and they sent other patients as well. But this is the issue. Dr. Srivastava, sir, what do you take care in counseling in these patients? And how would you manage in counseling terms, from beginning till the end?
Yeah, actually, best is to start this from the beginning before surgery. Yes. If you have an index case where there is a significant compression, like cervical myelopathy, I would say specifically, you tell that, see, I have seen patient who has come walking, though they have deficit, but they are able to manage to walk, but they can become grade 0 also. So this is a possibility, though it is a remote. And same time, we are not scaring also. Say it is like a walking on the road, but now walking on the jumpy road. So that is the situation. And when suppose in case it happens, then in that it is better to inform on the same evening, just after the surgery. Now I find there is some problem. and he is not able to, but we'll try to, treat the way it is described, definitely, without any doubt. And let's hope how he is going to improve gradually, we'll see. And I think that clear information should be there. Yeah, communication is very important. Don't avoid the relatives. Don't avoid the relatives. Only what happens sometimes, every time you will find a new relative. So actually that you should do in the prior hand only. In a risky case, you choose one or two relatives who are closer to the patient or who stay with the patient. People who are staying with the patient, I think you should have a good communication, and that most of the time you don't have any problem. And these patients and relatives become your very good, patient category.
Dr. Badani, sir, before we end, the last few points on what would you do to prevent post-op deficit in a cervical myelopathy case? What are the points that are important to be kept?
I think that one of the things that I do, when I use gel foam, I keep it outside the lamina. I don't tuck it in. So it remains outside all the time. It never goes in. So probably due to that reason, I have never had a problem with the gel foam. Secondly, I think you did whatever had to be done. I mean, you put a drain, you did everything. So this was an unfortunate event. I think beyond this, I think there is nothing else that you have not done to ensure that, patients should get good.
Yes, sir, Dr. Zaveri.
Sorry?
Any
Steps
points
that you will take to prevent a post-op deficit in cervical myelopathy?
So I think steps are all along the way. Preoperatively, I like to stop clopidogrel at least 5 days before the surgery. There is some literature to suggest that in general surgery and abdominal surgery, they don't stop. But you must remember they are cavitary surgeries, whereas spine surgery is a closed cavity, and therefore a hematoma can be a problem. The second thing is in positioning the patient. Be careful not to put the patient in too much extension, because before you start only the patient can get increased impingement and problems. Third is that during the surgery maintain the oxygenation. I don't allow the systolic to fall below 100 in patients with tight myelopathies. Fourth is obviously maintenance of oxygenation. Fifth is I always start steroids on these patients preoperatively. So I give steroid overnight. It goes on as a solumedrol or methylprednisolone goes on in a 1 gram in 500 ml of normal saline, starts overnight, continues through the operative procedure and continues for 8 hours post-operatively. So that way you give a drip just to reduce the edema from the handling of the spinal cord. The other thing that you can do is that you must work only in the lateral gutter. Do not work centrally. Sometimes we feel we did everything perfectly, there was nothing. But you are using big instruments, even a Kerrison 1 or 2, the foot plate is big enough in a tight canal to cause further compression. So work in the lateral gutter. If you have access to things like a harmonic scalpel, a high-speed drill, then you can burr the gutters, make a whole channel, and then lift up, do what is called as an en-bloc laminectomy. That reduces the risk significantly. At the end, meticulous hemostasis, keep a drain so that this is there. Also, you must remember that there is a huge trend, especially among the younger spine surgeons, to instrument spines, especially following laminectomy, etc. And they give excuses such as OPLL and all. That is all bullshit. Avoid instrumentation whenever unnecessary in the cervical spine. The risk of hematoma is much higher. The risk of some reason neurologic deficit is also higher. Chronic neck pain is higher. And proximal junctional kyphosis is also higher in patients with posterior instrumentation. Anyway, I think now lovely case there, Satyen. Thank you very much. So the patient's cord expanded quite well after your surgery, but unfortunately the patient did recover, but not completely so. And that is one of the problems. But in his case, to be fair with him, he got into the patient within 24 hours. The hematoma had not organized. With hematomas, it has been seen that the results are better when you go as soon as you detect the hematoma. The earlier the better. Do not wait, procrastinate. As Abhilash said, you should have a short threshold for attacking it. So go in early and attack it, because that's when the best results. Once the hematoma gets organized, then it's 3 or 4 days post the bleeding has started, then the chances of neurological recovery go down significantly. Thank you, Satyen. We now move on to Dr. Ketan Badani, who's going to present another case. Please join us on the podium, Satyen.
I welcome Dr. Badani. His case is the foot drop following L4-5 decompression plus or minus fusion. Welcome, sir.
The title is slightly incorrect, but anyway, it's similar. So, complications teach us a lot of things. This was a 51-year-old female patient who had a history of 2 to 3 year history of bilateral leg claudications, gradually worsening, difficulty in walking, and when she presented to me, she was already walking with support. There was a history of some lumbar spine surgeries done 20 years ago, around 1997 when I saw her, and all were anterior surgeries, and previous papers were not available, so I didn't know what surgeries and what further surgeries were done. On clinical side, the lumbar movements SLR was normal, but she had a significant deficit, as I have depicted here. It spared the quadriceps and the plantar flexors and was predominantly affecting the L5 bilaterally symmetrical, like something like a conus lesion. Although the plantars were not there, but the lesion looked like a conus lesion. And these were her MRI pictures. So as you all can see, there is compression at D11, 12, L12, L4, 5, L5, S1. On the right hand side, you can see a fused spine from L2, L3, L4, and adjacent segments are having degenerative stenosis. Satyen, Dr. Srivastava, your comments?
Multiple level stenosis is there, and neurologically on clinical examination you have a little mixed picture. So, any upper motor neuron signs?
No.
No. So, in this scenario, if the patient is having disabling issues, now she has deteriorated in this.
Deteriorated over 2-3 years. She is
2-3
having
years deteriorated.
deterioration.
And,
When she came to me the first time, that time this deficit was already there.
there. And what about diabetes? Is she having component
No,
of peripheral
no. She
neuropathy?
was not having any of the medical conditions. No.
Now, usually these patients now, who have gradually deteriorated since last 1 or 2 years, usually we have to warn them that there may not be full recovery. Because that is the one important thing. Because usually acute onset, I would not say it, acute on chronic is difficult to comment. But relatively fresher neurological deficit, which you having a matching situation in radiological investigation, usually they improve with the decompression. So, in this situation where there is a radiological compression as well as there is a neurological deficit, I think we should give a chance.
So basically, if I summarize the case, there was a previous lumbar spine surgeries, anterior surgery, all of the surgeries previous were anterior. We can call it a tandem stenosis because there's a cord and root compression, D11, 12, and the lumbar spine. There's adjacent segment disease. There is a neurological deficit where the lower motor neuron seems to be masking the upper motor neuron lesion. So I don't think everybody agrees on this point. What she needs surgery, Dr. Zaveri?
Yeah, we should go ahead with surgery, but we need flexion extension views here to see the evidence of instability at the proximal junction of that fusion and distal junction of that fusion.
Yeah, some of those my files had become corrupt, so I could not present those. But at L4-5 there was instability. Other levels were okay.
All right. So
because we are discussing complications.
Let's put the this thing, go further and say that yes, surgery is required. You would do a decompression at the proximal segment and at the distal segment, and if there is a problem of instability at the distal segment, that is at L4-5, then I would fuse 4-5 also.
Gautam, you have addressed this, but on the last question was that in this patient there is a loss of sagittal imbalance. Would that be any point of consideration at this point? Because the patient has mainly come for leg symptoms and walking difficulties.
So the sagittal imbalance is always a consideration, but I wouldn't do a special osteotomy or anything for this. I would just try to do a L4-5 discectomy and an interbody fusion, and whatever correction I can get from the interbody fusion by putting a cage, I would do that.
Okay.
Wouldn't do too much more.
Okay. So, I did laminectomy at D11-12, skipped the D12-L1 and decompressed L1-2, L4-5, L5-S1 and stabilization L4-5 with interbody and screws. I did not attempt to do any correction of the kyphosis or anything. So I would like to know, Dr. Abhilash, would you agree with what has been done, or you think that you done something different?
Probably do the same.
Would you have considered going to S1?
So, assuming that you have a huge block of fused bone above, if I have to go to S1, then I'll be obligated to do an iliac fixation because a huge fusion mass sitting on top of my L5 S1.
Yeah.
And S1 screws will be notoriously weak.
Dr.
Definitely
Nikhil,
do a short segment now.
I have excluded the D12-L1. Is that a hindrance, or should I have done it, or should it's okay to leave it? Because there was no compression at D12-L1. The D11-12 showed the cord compression.
Yes. So she came mainly for the lower motor neuron type of symptoms like claudication. So main job required to be done is at lower lumbar spine. Upper, because it has been seen and it has been compressed.
No, there is cord edema there. There is cord edema here. You can see the cord edema here. Okay.
Yes. So the
And
decompression part
Dr.
is
Ketan,
sufficient.
now if you see the whole long screen view, so there is not much of a change in the balance. The dorsal spine is not that much kyphotic.
Yeah.
So overall the alignment is quite acceptable.
Okay. So now we'll go to the main problem that occurred post-operatively. There was localized pain in the left thigh anteriorly. It was quite localized. It was not radicular, as if coming from the back down. It was a constant pain with intermittent shooting, which she complained immediately post-op. When I tried look, because the pain was bang anterior, I thought it could be something with the hip which has been missed or something, and with the hip movements there was increase in the pain. The quadriceps power, which was originally 5, was also not much reduced. It was 4+, and I thought it may be weak due to her pain. It might be apparent weakness, not a true weakness. And there was no tingling numbness. So, Satyen, what would be the likely causes of these symptoms?
Yeah, it's a bit strange. If you put in your implants are at L4-5, and getting an anterior pain does not match the roots. It doesn't look like it is related to handling you.
Which level?
At
Two.
a higher level, if
Higher
you're
level.
talking
Okay,
about L2
okay,
or
okay,
3,
okay.
doesn't look like you've done much. So I may actually be thinking maybe you've missed something. Does she have a hip pathology together with that? Maybe during positioning you've had some pressure on the hip, got extension of the hip joint and caused some problem there. These are the things that I'm just thinking of.
One possibility is hip.
in my
That
mind.
look like that only.
Yes.
Dr. Zaveri, please tell us what would you do with this very severe pain, and but it was localized and intermittently increasing.
No tingling, numbness, no weakness.
No tingling, numbness. Weakness was the quadriceps appear to be slightly weakened, but because of the pain, it could be poor response from the patient.
The first thoughts in my mind would be what could be the cause. And as Satyen said, you start from the beginning and your first cause would be positioning. Sometimes the bolster which you keep can abut on the anterior thigh and you can cause compression of the femoral nerve, and which can result in pain or weakness in the anterior thigh. Or just direct impingement of the bolster on the thigh could also cause pain. The second thing which could be there is that maybe there is some Sometimes what happens is when we decompress, patient had probably symptoms on one side, and you decompress obviously stenosis both sides, then suddenly the inflammation of the root on that side, they start complaining of pain on the opposite side, which they didn't have earlier, and they are very unhappy about it, but it's going to settle down. So that's a second possibility that is there from the handling of the nerves. The third possibility is, of course, a hematoma, which could also still be there. The fourth is there could be some implant impingement, but again, as Satyen said, there's a mismatch between the level of where you have done the implanting and the level where the pain is. So these are some of the issues there are there. Now the question was, if it was in the first day itself, then I would still wait and watch, maybe give a little bit of steroids, anti-inflammatory, wait and watch, because I wouldn't be no hurry. I'm expecting the patient to get a little bit of pain. On second and third day, and if on mobilization patient has increasing pain, then obviously I'm a little worried and I would like to investigate. In this case, you have to investigate with everything. You have to do an X-ray, you have to do a CT scan, and you have to do an MRI. Each one has a different role over here. The MRI will show you the exact source of compression, the neural elements, etc. The CT scan will show you where the implants are. Is there any malposition? Is the back out of the cage or the screw are misplaced? That's what it will show you. So, and X-ray is going to be what your follow-up is going to be.
Yeah.
So you need a baseline. So get all these investigations
I'll
done
go ahead and show that this is the post-operative X-ray. Nikhil, anything?
Doesn't seem to be very, the screws are well placed medially, but I would like to check the position of the screws on the CT scan. That's it. I would not consider anything else. The cage is in the well placed.
So basically, as Gautam was saying, hip injury during positioning, some existing hip pathology which was missed, or I thought even a stress fracture of the femur which had just come into play. And I did the CT scan of the hip and the spine as well. So I found that the screw was misplaced.
Maybe the left side screw appears a little bit more medial, isn't it?
Yeah. You see here, it is going from here, and as you can see here, the trajectory is more medial.
So as we all know, pedicle screws in the lumbar spine have very little room for error medially and inferiorly. If you are breaking out of the pedicle superiorly or laterally, there is not much worry. But if you are breaking through medially or inferiorly, then the chances of nerve impingement are very high. Sometimes what happens is just that you've put the screw, still may not be outside the pedicle. Only when you are putting the screw, the thread, the cortex of the gets cut through. The screw has good purchase. But because the nerve root is so close, it keeps on irritating the nerves. There is inflammation and that causes the pain.
So if you see this carefully now, you can appreciate that this screw is quite medially angled, and that was the cause of the deficit. So shall we discuss further this?
I think we can go ahead with the lecture because we are running short of time.
Okay, fine.
But I think this year...
So I will just highlight a few important things in this. What about the, what precautions do you take when you change these screws? Satyen?
So we'll have to maybe do an in-out in technique type. We have to go more lateral. Over here you've also put in a little bit superior, so I'm sure there'll be more space on the other side. Maybe you'll have to put in a smaller screw also in terms of width, because you don't have too much of bone left. So maybe a 5 mm screw, but it can be reasonably.
You expect dural tears?
Dural tears also an issue, because you already got an impingement. So you have, when you're taking it out, you have to protect the nerve root while you're extracting the screw. But it's still a little weird presentation, because the L4 nerve root should not cause this kind of.
It was not very clear cut, but that's the.
Yes.
Thank you.
So you saw 2 cases of post-operative neurologic deficits, and that's what I'm going to be talking to you about. This is patient 1, a 47-year-old lady. She had progressive spastic paraparesis. She had grade 3 power in both the lower limbs. She underwent a transthoracic decompression for the OPLL, which you see, and she got up with complete paraplegia. If you see the MRI on which is done post-operatively over here, you can see that the decompression has been perfectly done. There is no more compression left, and there is no significant compression. Is this a hematoma or is it just the empty spot? What is it? And what should I do next? That is the question. A 57-year-old lady, back pain, left leg pain, typical symptoms of spinal canal stenosis, had a left instrumented T-lift with bilateral lateral recess decompression. In the evening, her left leg pain had disappeared. She had mild discomfort in the right leg. Patient mobilized comfortably. But over the next 2 days, she got progressively mobilized, and as she got mobilized, she started complaining of increasing right leg pain and paresthesia. X-ray was done, and X-ray showed that this screw was a little inferior compared to this screw. Does it really matter? And so we got a CT scan done, and CT scan showed that this screw was going through the foramen and impinging the nerve. What next? A 77-year-old lady, she underwent a Whipple's surgery under general anesthesia. Epidural catheter was inserted. She was started on Clexane 0.4 international units subcutaneously postoperatively. 24 hours after the surgery, she complained to the surgeon that she had paresthesia in the left lower limb. It was thought that this was because of the epidural anesthesia that was being given. 72 hours post-op, she complained of weakness in the left lower limb, unable to move. Again, it was attributed to the epidural anesthesia, but at that time and 96 hours later, she developed a weakness in the right lower limb. The epidural catheter was removed and MRI was done. The MRI showed a large epidural hematoma secondary to that epidural catheter. What next is the question, and that's what I'm going to answer for you. What should you do when you get a post-operative neurologic deficit? This is a dreaded complication, and it is far more common than everybody comes out with. The incidence in literature varies between 0 to 10%, and this variability in literature is primarily because different types of cohorts of patients with different types of pathologies are reported. The definition of a post-operative neurologic is different for different people, and the follow-up also of patients is different, and therefore there is a difference in the variability of incidence. With spinal stenosis decompression, Global Spine Journal reported an incidence of 2.8%. With lumbar discectomies, a post-op neurologic deficit of 0.21%. With scoliosis correction about 2%, and complex adult spinal deformities almost 22%. When you look at classifying these neurologic deficits, there are 5 types. The first of which is new onset pain, basically radiculitis or sensory loss. The second grade is a unilateral motor weakness. Grade 3 is a bilateral motor weakness. Grade 4 is a cauda equina syndrome. And grade 5 is a complete paraplegia. What has been the common etiologies in most of the studies that have been done? The first and foremost is an epidural or a subdural hematoma, misplaced instrumentation, direct surgical trauma to neural elements during the decompression or secondary to a correction of deformity, incomplete decompression of neural elements, that means persistent compression of the nerves secondary to a retained disc and incomplete stenosis decompression, positioning as Satyen mentioned, and sometimes you don't know what is the cause. You've done a good job. It might just be called edema. What is the management? I think the management starts preoperatively with meticulous documentation of the symptoms and the neurology. An appropriate counseling and consent is vital. The complication should not come as a surprise to you or your patient. If that happens, the patient loses faith in you and develops distrust in your abilities and care. So do not overpromise patients. The next thing is detection. Immediately post-operatively, you must do a neurological examination after the patient is conscious and alert. And the findings must be detected meticulously and documented. As Satyen mentioned in his case, the deficit started only about 4 to 5 hours after surgery. And it was good that his RMO was so vigilant that he noticed the symptoms and signs early in the course of the disease so that appropriate action can be taken. Neurological examination must be repeated and documented on several occasions over the first 24 hours and during the stay in the hospital. Once a deficit has occurred, your patient wakes up in the recovery, you see the patient has a deficit. The first thing you do is you review the surgery with your surgical team, the anesthetist, find out when you are doing a cervical stenosis decompression, was there any drop in blood pressure at any time? Was there a drop in oxygenation? What happened? Why has this, were there any step you personally feel could have led to this deficit? Then the second step, as I said, was maintenance of blood pressure and oxygenation is vital. Check if your drains are working adequately. In the dorsal spine and lumbar spine, if you are suspecting a large hematoma, turn the patient immediately to the side. Sometimes, because of the closed compartment, there is back pressure. If you turn the patient to the side, the pressure immediately reduces, patient may feel better. And at this is the time to consider IV methylprednisolone. The next step is how to deal with your patient and the relatives at that time. That is also vital. First, you need to calm yourself, take a deep breath, think out what you are going to tell the patient and relatives. And you must discuss this with your entire team, because entire team must be on the same page when talking to the relatives. Sit with the relatives, explain the problem, the cause, the steps to be taken, and the prognosis of this condition. Avoid retaliating to patients or families' angry outbursts at this situation. Obviously, they are worried. Obviously, they don't know what is going to happen to them, and therefore, they are going to be upset. Then you go on to what is the possible diagnosis. If it's an immediate postoperative deficit, think of direct trauma to the neural structures. Think of a misplacement of your spinal instrumentation. Think of problems during correction of spinal deformity. You have overcorrected and that has caused it, or an inadequate decompression or positioning. If it is a delayed neurologic deficit, think of an epidural hematoma which has gradually expanded. An inadequate decompression, a correction of a deformity can also result, especially kyphotic deformity. What happens is when you correct a kyphotic deformity, gradually the blood supply may go down over time and patient can develop a neurologic deficit. In such patients, neuromonitoring is recommended to be continued for the 24 hours after the surgery. Displacement of screws, wires, cages and bone grafts. And late onset deficits is because of epidural scarring, arachnoiditis, infection and instability. Get appropriate investigations at this stage. Do not keep on thinking about money. This is the time when you need to be aggressive and try to find the cause. So here you can see that there is a spinal cord edema, which is because of direct injury to the cord during the surgery, an epidural hematoma, a subtly misplaced screw. Over here, this was a person who underwent a pedicle subtraction osteotomy. The lamina is impinging on the dural sac, and this is a cage which has backed out and resulted. And all of these can be picked up fairly all right with CT and MRI. And finally, you come to the treatment. You must remember, do not procrastinate. If you are worried about your decision, get a second opinion from a senior colleague. But reversible causes must be dealt forthwith. If you know that there is a hematoma, if you know there is a misplaced screw, operate early. Early resurgery offers the best chance of neurological recovery. In the absence of a reversible cause or an unknown cause, just exploration because you want to do something for the patient is not advisable. So in this patient, where an adequate decompression has been done and there is nothing else you can do by re-exploring this person, please keep your hands off the patient. Start steroids, do the oxygenation, blood pressure bit, and be patient and pray. In this patient where there was a misplaced pedicle screw, go in early, revise the pedicle screw in the appropriate fashion, patient gets complete relief of symptoms. And in this patient where there was an epidural hematoma, even though the patient was 7 days post the epidural hematoma, I went in immediately and operated, evacuated the hematoma. The hematoma already organized into a thick clot. I had to separate it gradually, wash it out, but she started recovering the very next day. So the outcomes of post-operative neurologic deficit have been very clearly seen that if there is a definite cause, then appropriate surgical treatment is useful when it is done early in the disease process. So take-home messages: new post-operative deficits following thoracic or lumbar spine surgery are far more common than are reported in literature. Most deficits are subtle, hence careful neurological examination is vital. Always listen to the patient's complaints. Don't think this patient is a cribber and avoid listening to the patient. Early surgery in patients with clearly identifiable and reversible causes offers the best chance of neurological recovery. I would like to end with this slide, which is very vital for all of us surgeons. We don't want to believe, we don't want to hear, we don't want to talk and accept that complications occur at our hands. The earlier you realize the disasters you can do, the earlier you will make your patient better. Thank you.
Thank you very much, Gautam sir. This was a very good session today. The session is open for question and answers if anybody has it.
Good afternoon, faculty. I'm Dr. Dhanashekhar Raja. I'm an orthoplastic consultant from Ganga Hospital. So we reported a case of epidural hematoma causing paraplegia. And probably 24 hours later, the epidural top-up, we diagnosed that patient had an epidural hematoma, not the effect of epidural anesthesia. Then we sent the patient for MRI, and once the patient come back for MRI, we posted the patient for surgery. Then the recovery started. She was totally paraplegic. In the preoperative holding room, she started moving. So we treated conservatively. She completely recovered. So what's your comment on that? Will you still go ahead and operate, or you can try a conservative trial?
The patient is already showing signs of improvement with your steroids and with the time that has been spent, then you can afford to wait and watch and see whether the progressive recovery is happening. What has been found is that with conservative treatment also they recover, but the quality of recovery and the completeness of recovery is poorer. So what happens is there is a difference between anecdotal reporting and a series of cases. So in your case, it's one case. We need to see whether 100 cases treated conservatively such improve and to what extent they improve.
But so the patient itself was a high-risk patient for taking it back, post-oncology patient recovering. So we thought...
So you have to consider all these
individual patients
also, individual things. Yes,
Thank
absolutely.
You. Thank you.
Mukhi sir.
There was a case of a large sequestrated disc at L2, L3 on the right side. And we did a fenestration and removed out that piece. And believe me, there was no distraction, hitting on any of the nerves. Post-operatively, total paraplegia.
What you must have investigated with MRI.
Yes.
What did you find?
Nothing came on the MRI.
Dr. Srivastava, with your wide experience on this subject, would you like to offer some advice or some solutions or insight?
You told L2, L3 disc.
L2, L3,
So there is
fenestration, not interlaminar, and removed out the sequestrated piece, and post-operatively both the legs not moving.
So I feel there might be two possibilities. Higher disc, and if you see, when you wish to take out the large disc you told, one might retract the sac significantly. That is the one reason. And as you told, fenestration, rather interlaminar is better, that you have created the space, some breathing space for the neural sac. So fenestration in a large disc at higher level, all the possibility of deficits are there.
Satyen, you also wanted to make a point?
That at L2-3 level, it is actually not advised to do any fenestration surgery. At L23 already the canal is, the space is much lesser. It's always better to do a proper laminectomy and do the discectomy. It gives much more breathing space.
Sometimes there is an element of constitutional stenosis, which is missed out by the radiologist and the surgeons. And when you do these higher level discs and you don't decompress the other levels which might be stenotic, you could land up in a total deficit.
Luckily,
Patient recovered?
yeah, patient recovered.
Lovely.
We started giving methylprednisolone. She recovered on the unaffected side, and touch wood, she's walking today. MRI showed nothing. I have a MRI machine on the ground floor. Immediately I took her MRI. Immediate. It was not showing anything. And this is what Srivastava ji has said. Exactly I felt that. Okay, the cord or the cauda equina was little bit retracted more, and sudden decompression was the thing.
So yeah, sir, as very, very good point you are making. And I think what is important for us to realize is that the magic pill is methylprednisolone. Vikas, please go ahead. And MRI.
I just want to make a comment about Satyen's this thing, that laminectomy has to be done. We have been doing tubular discectomy for years for almost all cases, high-level disc as well as cauda equina syndromes, central disc. We didn't find any problem using a tube. Adequate decompression is key, and main point is when you go to the center, towards the center, drill the base of spinous process like you do over the top decompression, and then do the discectomy, because you create adequate space. Probably, I don't know about Dr. Mukhi's case, but probably only fenestration, probably he has not done the base of spinous process decompression.
Good point
For the
there.
comments, I think we need to close the session.
Yes,
please.
we need, sir. We need to close the session. Sorry.
Thank you for the
And thank you very
Thank you
much
all.
to all the panelists for a lovely, lovely discussion. I hand the mic to the chairperson.